I'm going to talk about, oops, too fast, just summarize what's been discussed earlier and just maybe highlight some of the next steps, because you may be thinking, wow, but then what happens after this? Because you've probably realized there's some gaps in the pathway. So what we're really hoping to do with the pathway, I think more than anything else, is standardized care. I hear from physician colleagues, and as Rhonda mentioned, I was on a 4-month contract and kind of loved L'Orange and ended up staying 9 years. But it was a really good time for me because I realized what it's like to practice with few resources. Having now worked in the city for 15 years, I kind of struggled to go back. But the reality is, in some of the smaller rural communities, you can get a lot more done. But it is hard to do things when you're trying to invent the wheel for the first time. So what we're really hoping for is standardization. I hear from colleagues and all across the mountain, the nurses have no protocol. They don't know what to do with wounds, or the nurses change every few months. And so what we're really hoping for is standardization. I think that in itself will result in improved outcomes. But what I'm looking for as a care provider is communication. Even in Saskatoon, I refer someone to home care for wound care, and I never hear a thing until there's a complication or they need an antibiotic. So I think for primary care providers, both physicians and NPs, it's going to be really good when we hear back from the wound care nurses saying, yes, we're going to implement this. And we'll contact you not only in crisis, but just to kind of keep you informed. Because it's our job as the primary care provider to help the patient stay motivated. Compression dressing is not fun. Offloading is not fun. And compliance or adherence to that is key. And I think everyone in the team needs to be kept in the loop, and that's not what's happening now. And I think standardization and communication in themselves will hopefully go a long way to improve outcomes and save a lot of frustration, both for patients and for care providers. So for providers, we're creating standardized tools and protocols. I'll be working on the education section for physicians and NPs. We're hoping to have online education tools, deliver WebExes to interested parties. We're kind of all in hiatus with the election coming up, but that will be part of the plans for the next year. Michelle mentioned there was a hope for distance consultation. If you've been around in healthcare long enough, I happen to be consulted to be part of the first demonstration of telehealth for the province. And telehealth just hasn't delivered because part of it's based in a hospital or a health center, and accessing time and everything is difficult. So we're hoping to actually have desktop consultation services. So Dr. Elmer and his team, one of his colleagues may be in St. Paul's, they've got a laptop, and they can consult with Michelle or her team members in North Battleford without booking a telehealth suite. So it takes IT, and we all know IT is lots of silos at the moment. None of the EMR or EHRs speak to one another. So we're trying to break those barriers, but I think that's going to go a long way to improving outcomes and really helping delivering services in patients' home communities. And also perhaps reducing hours, because as a wound care nurse, you will be able to get communication directly with either one of the vascular surgeons or one of the urban-based wound care nurse specialists, and not be stranded on your own, feeling that you have no one to support you. I think the nursing course is going to enable opportunities, especially the 2-day lab, where you can meet your peers and kind of realize, okay, I've got someone else I can link with and get assistance from. And you may be a small or a geographically large but small population health region like some of the northern ones, where you're not going to have a wound specialty resource person. So how do you find the care, the access to peers that you need? So this pathway will help develop some of those things. So the plan is, that we will be implementing the various phases that have been talked about today over the next year. We had hoped when we started this project that we would have a pathway for wounds and we'd have a pathway for non-ulcerated high-risk diabetic feet, because those are the ones that we want to prevent wounds in. Unfortunately, until the price of oil and potash go up, we're not going to get dedicated dollars for that. But we're working behind the scenes to try and improve access to services for those individuals. It's kind of sad that you have to have an amputation before you get specialty footwear funded. And so we have a team of people, and that's the one nice thing about the pathway, it's being able to draw together people with different expertise. And we're going to actually try and change maybe some of those funding rules through SaskAbility and SAIL. It's probably not going to be in the next year, but we're going to start on it. Because that's my passion, looking after people in my office with diabetes, with a high-risk foot. I don't want them ulcerating, okay? And those are the people who are also at very high risk. So Michelle mentioned once the wound's healed, whether it's venous or diabetic, the wound care nurse sends them back to their family physician or the nurse practitioner. It's then my job to convince them that they need to wear those horrible compression stockings even when it's plus 30 outside. And it's a hard job, it's a hard sell. And they need to wear clumsy looking, not fashionable footwear if they've had a diabetic foot. But offloading is the most important thing. Offloading is more important than what you put on the wound for the dressing. And you know, the pathway, while we're focusing on the wound, I'm hoping the next step is going to be focusing on prevention and preventing wound formation.